what's going on with the patient, help us start making that differential, which you should have, if you haven't had it yet, you will in your clinical, you'll have some GI cases where when you're getting out that history of present illness and review of systems, then you start to kind of glean out what's in your differential. Because patients don't walk in kind of saying, I have functional dyspepsia, right? That's not what they're going to present for. They're going to say, oh, I'm nauseous, or my tummy hurts, or whatever their signs and symptoms are. But then you got to drive it back down to what's the etiology, where's it going on in the abdomen. So basically you have to be able to localize it first, then categorize whatever issue the patient's having. Then you look at risk. Is this a young patient with 2 to 3 days of nausea and vomiting? Am I that concerned? Or is this a 70-year-old that's been hospitalized and now they have severe irretractable nausea and vomiting or diarrhea? It's a very different approach to those 2 types of patients. So that's when we'll talk about risk stratification per disease. And then you decide, hey, what do I need to do? How do I work this up? What tests do I need to do? Do you really need labs, an EGD, a colonoscopy on a 25-year-old with 3 days of nausea and vomiting? No. Same way, but you don't need any of those tests, right? But now we'll go back to that 70-year-old. Yeah, you probably need every workup you can get to figure out what's going on with this patient. So a lot of this is pattern recognition. In the lectures today, it's an intro, right? So I'm going to be hitting on some disease processes, but we're not going to go in depth. We're going to focus on a lot of symptoms and signs, right? We'll talk about nausea, vomiting, constipation, belching, gas. But then when I bring up some concepts for like nausea, vomiting, diarrhea, we'll hit on those disease processes, but in later lectures, you'll see that I'm going to reference, we're going to hit them much harder. Like when we talk about like a Mallory-Weiss tear today, briefly, what's going on. But then when we get into the esophagus later in the week, we'll get down and dirty with exactly how to make the diagnosis, the workup, and the treatment. Learning objectives, you can read them if you have a chance. Basically, patient's going to present with GI complaints. You're going to figure out what's going on, how to work it up, and how to treat it. These are the tasks that are associated with our 4 big topics. For this lecture, dyspepsia, nausea, vomiting, hiccups, and gas, including belching and flaps. All right, forming diagnosis. You want to start thinking early, what organ is located where, right? So we're going all the way back to A and P, learning all those different areas of the abdomen, those regions. So you start with what's located where the patient's got a problem, right? So if someone says they have epigastric pain, you want to start thinking, okay, I need to be thinking stomach etiology, maybe the top of the small intestine, duodenum. Pancreas can present with epigastric. Biliary tree, heart, right? So chest pain can be MI related. It can be heart related. So I want you to briefly look back over those quadrants, right? Don't really memorize the list, but just think about what's located in those regions of the abdomen. And this should be a review. If you need further review, obviously go back and look at it. In the card for this class, there's some links for anatomy reviews if you need to look at it for specifically GI anatomy reviews. And I think also some slides on imaging, which we'll talk briefly about special studies. But if you want to dig deeper, that resource is there for you on the left middle side of the card. So remember the quadrants. And then we start thinking about, well, if I have an issue going on, where's it going to present? Well, some of these are overlapping, right? And this is when we talk about the specific disease processes, we're going to say, hey, like, for example, you'll see appendicitis on there twice. Why? Because classic presentation starts in one area, then migrates to another, right? So you see it under the umbilical region or periumbilical region, early appendicitis, then right lower quadrant as it progresses, because that's the classic presentation. But this is a good overlay of if the patient's saying it's hurting here, they're pointing to a certain area or region of the abdomen, start forming that differential early is, all right, what's in that area that can be causing the issue? It can guide you sometimes to the workup and how to rule out differentials, because obviously there's not just one thing in each of those quadrants. So if you think it's something, also helps you form your differentials to rule out or rule in what or why based on where it's happening in the abdominal region. I mentioned today dyspepsia, nausea, vomiting, hiccups, and then burping and gas, flatness. These are all symptom clusters, right? None of these four right now are we talking a disease. We're talking symptom clusters that some disease processes can have. Dyspepsia. People misuse the term all the time. Dyspepsia is epigastric pain or burning, or with early satiety. What's that mean? Anybody? What's early satiety? You feel full, eating a little bit, right? Postprandial fullness. You feel extremely full after you eat. Heartburn is not dyspepsia, right? I said dyspepsia, epigastric. Where's heartburn usually? Talking a lot of times substernal, right? It's a little bit higher than the epigastric region. Doesn't mean it can't hurt in the epigastric region if you have peptic ulcer disease or dyspepsia, but if you have epigastric pain or burning, early satiety, and postprandial fullness, think dyspepsia. Retrosternal, probably GERD. Nothing is always, right? Because our anatomy can be a little bit different in each human being, but these are usual guidelines, right? So dyspepsia causes food intolerance, overeating, indigestion is acute, is self-limiting. Alcohol can cause dyspepsia. Most young patients fall into this, right? This etiology, food or drug intolerance. Some medications that can cause dyspepsia: aspirin, NSAIDs, antibiotics, diabetic meds. There's quite a long list. And then good old alcohol and coffee can cause dyspepsia. Functional dyspepsia, most common chronic cause. Know that. So here you have symptoms without a structural disease. You do a full workup, and you've got normal labs. You've got normal endoscope. And we're going to talk about an endoscopic exam in the next few slides. Or you have ongoing symptoms, and you have ongoing symptoms, but you found no lab, no imaging to rule out or in other more serious issues. That is functional dyspepsia. No organic etiology. Diagnosis of exclusion, but it's the most common cause of chronic dyspepsia. Notice chronic, not acute. Most common cause of chronic dyspepsia. So for functional dyspepsia, one or more of the list there. Postprandial fullness, early satiety, which we defined, bothersome epigastric pain, and bothersome epigastric burning. One or more of those, and a normal workup. Nothing structural, nothing on the labs, no sign of infection. In other words, you can't explain it, but they have one or more of the criteria above. It's functional dyspepsia. Most common chronic cause of dyspepsia. But now we start looking at organic etiology. So when you're working it up, then we can find organic etiology so we can have luminal GI tract dysfunction. We'll start thinking about GERD, peptic ulcer disease, H. pylori. And I know y'all talked on some of these. I know in Pharm and some other courses, and we'll get deeper into them as we get more into the course. But for now, just know that these are some of the organic etiologies of dyspepsia, because dyspepsia is not a disease, symptoms. Gastric cancer, gastroparesis, pancreatitis, biliary disease, MI, yes, epigastric pain can be of cardiac origin. A lot of times on boards, you'll hear diabetic with epigastric pain. So you want to start looking at cardiac. So epigastric pain can include MI or other cardiac etiologies. Infection, H. pylori. I know you had it in antibiotics, sophomore, I think, or last semester, correct? So that should be, old news. We'll hit on it briefly, but you should know the treatments and how to work it up, diagnose it, and then confirm that the treatment worked. Other organic etiologies, like I mentioned, gastric cancer, pancreatic biliary tract disease, diabetes, thyroid, chronic kidney, MI. So quite a few organic causes of dyspepsia that, if you rule all these out, dysfunction. So for clinical findings, chronicity, location, quality, duration. You want to know that. You want to know relation to meals. We just talked about the symptoms of dyspepsia, right? That early satiety and postprandial fullness. So you got to ask about meals and how their pain is related to the meals. Talk about what they're putting in their system that can cause it, right? Alcohol, caffeine, spicy foods, any recent changes in diet, exercise, or psychosocial changes. And then we mentioned some of the serious things. So if you got fever, chills, weight loss, nausea, vomiting, diarrhea, probably not functional dyspepsia. We need to do further study. Those alarm bells are going off. And here they are. Unintended weight loss. You got the signs and symptoms of dyspepsia, which we discussed, and you have unintentional weight loss, dysphagia. What's dysphagia? Difficulty swallowing, right. Recurrent vomiting, any type of bleeding, meaning from your GI tract, either out your mouth or out your rectum. Anemia. If you do your CBC, do your workup, if you got anemia, it's not functional dyspepsia. It's an alarm. We need further investigation, further studies. Ask about family history of GI disorders, right? GI cancer specifically. Know the last bullet. Dyspepsia onset, if you're over 60, you're getting an EGD. You're getting an upper endoscopy. Know that age, right? Because there's some other alarms for other disease processes that have ages associated with it. But for dyspepsia, if you have these alarm systems and there's alarm symptoms, or if you just have symptoms of dyspepsia that are starting over 60 years of age, you want a full workup. They get an EGD. So, clinical findings. You do your physical. Usually nothing, right? Except the gastric. Can have some mild epigastric tenderness, palpation, if anything. But look for other systemic things going on, right? Color of the skin, jaundice, yellowing of the icterus of the eye, scleral icterus, lymphadenopathy, cachexia. What's cachexia? Yeah, so wasting of what? Muscle and fat. Unintended wasting of muscle and fat. Pallor, so pale. If you have presence of organomegaly or TTP, start looking at other things. Further workup. So our routine kind of workup that we're going to do on dyspeptic patients, CBC, CMP. So you've all had, you know what those labs involve, right? You know what we're looking at. Amylase lipase, what organ is that check? Pancreas. Thyroid panel, obviously can lead to some of these symptoms. And H. pylori, we talked about it, we'll talk specific about it today and tomorrow. Other tests as warranted, celiac disease antibodies, we'll talk about celiac disease and the antibodies you look for that cause those signs and symptoms of celiac disease. And then stool for ova parasites. That's literally taking a stool sample. Usually it's like 3 days or 3 different collections, send it off to the lab, and if you have a parasite, they're actually looking for presence of the eggs, the ova, or the actual parasites themselves. We'll get into that. So, upper endoscopy, further evaluation. If the signs and symptoms suggest something other than uncomplicated or functional dyspepsia. If you're thinking ulcers, esophagitis, cancer, those alarm bells are going off from the alarm systems. We can get an upper endoscopy, EGD. If you're over 60 new onset, EGD. If you don't have alarm symptoms and you're less than 60, we can do some empiric therapy. We'll talk about what that is on the next couple of slides, but shocker, it's a PPI. After you test and treat for it. The big thing there is what I've hit a couple of times now. The age with with alarm symptoms, you're going to get EGD. So everybody with alarm symptoms, EGD. Everybody over 60 with new symptoms, EGD. Otherwise, empiric therapy. Here's an explanation of if you want to say the word on top, go right ahead. I do not. It's EGD to me. But basically, it's the name of the test shows you where you're looking, right? Esophagus, stomach, which is the gastro, and then duodenum, upper part of the small intestine. EGD, top to bottom, right? Differentials, they are long, but I hit a lot of them there. Don't expect you to know every differential, but just think about it, right? If the patient's having burning or painful epigastric pain, but they have other signs and symptoms other than just the postprandial fullness or the early satiety or those few things that we talked about, then you need to start thinking about these differentials. And that, if you really want to think about it, these are good ones to look at so that when you have those GI cases in ClinCore as you're working through phase 2, you can keep this list of differentials in mind to rule in or out based on epigastric pain. And the list is long. So, empiric treatment, we said they're under 60 with no alarm symptoms. We're going to give them empiric treatment. First, we're going to test for H. pylori. What are the tests that are preferred for H. pylori?
Breath test.
Okay, so there's the urea breath test, right? You take a pill coated, got a marker on it, and then if they detect ammonia, H. pylori is breaking it down. You can also do what? A fecal test, and you can also do blood tests like serology. Which one's preferred? Either the breath or the fecal, right? The serology is not as accurate. And then you're going to say, okay, it is H. pylori. So you treat, and we'll talk about what that is, but you should be remembering triple or quadruple antibiotic therapy. If it's negative, then you start those 4 to 6 weeks of empiric therapy with a PPI. You should remember what the PPIs are, right? Little purple pills. So, empiric treatment under 60, no alarm system or symptoms. H. pylori spiral gram-negative rod. You should know that for micro. I'm not going to ask you that, but it's a major cause of peptic ulcer disease. So that's why if we're moving towards empiric therapy, we're going to check for H. pylori first. We talked about the testing and patients with dyspepsia, chronic GERD, or suspected or confirmed peptic ulcer, we're going to test them. Fecal antigen or urea breath test is preferred because they're very specific and they're very sensitive. That means it can figure out if it's positive that it is a disease process and also which one it specifically is. Serology is less accurate, and so after we treat, what do? We retest, preferably with the same testing method. How long do we treat for H. pylori?
26 weeks.
2 weeks, 14 days. That's a board always question. With triple or quadruple, and there they are. You should remember from last semester. Most folks don't get triple, to be honest, because almost everyone has had a macrolide in their life. Do you remember back from last semester that if you've had any macrolide exposure, then you don't go with triple therapy? Was it taught that way? That if you've had any macrolide exposure for any other problem? Well, that's usually how we make that decision. We're not going to get that deep in here because that's more of a farm thing. But you can do triple or quadruple. Obviously, if you're allergic to something in the triple therapy, then we have alternates. I normally, a lot of times, see the quad therapy given more because people have had macrolides. So a PPI, you choose it, whatever you want. And then with the quad therapy, we add pepto, tetracycline, metronidazole. And if you have, if you're doing triple therapy, but the patient's allergic to amoxicillin, you go ahead and go to metronidazole. 14 days is the rule. If your patient fails H. pylori treatment, i.e. positive in one of those two preferred methods, you treat for 14 days, they come back in, you retest them, they failed that therapy, guess what they're getting? The EGD. Dyspepsia treatment. So functional, most common chronic cause. You've ruled out all of the possible organic causes, lifestyle changes, all those things that can cause it, stop doing that. Eat smaller meals. Keep a food diary. What are you taking that's making it worse? So limited efficacy with farm therapy. PPIs, that's our go-to. That's why we use it in that empiric therapy if there's no organic causes or alarm symptoms. There's some literature out there supporting antidepressants or TCAs or prokinetics like metoclopramide to decrease gastric emptying time for functional dyspepsia. Also, we can do some psychotherapy or cognitive behavioral therapy. Set your expectations because a lot of times these patients don't cure, right? We just start looking at lifestyle changes, trying some of those medications, but sometimes these patients do not cure. Moving on to nausea and vomiting. Define it, right? It's up there for you for nausea. Nausea does not equal anorexia. Anorexia is just decreased appetite. Nausea is that disagreeable sensation of sickness, queasiness. If you start to actual vomit or choose one of the slang terms there on the slide, that does not equal regurgitation either. So with vomiting, you're going to have material coming up and you're going to have forceful material, right? You're going to have retching, spasmodic, respiratory, and abdominal movements. Vomiting isn't regurgitation. Regurgitation is more passive. You hear patients say, oh, I get this acid taste in my mouth. More passive versus vomiting is an active action. Vomiting, 4 major pathways. Probably talked about them in form. I know you did. If you had the same slide deck I just talked to the sophomores. So, 4 major pathways for vomiting. GI vagal stimulation, those 5-HT3 receptors, the vestibular system, the higher CNS centers, and then the chemoreceptor trigger zone. So different pathways cause vomiting, nausea and vomiting differently, which are treated differently. So chemo patients, they're going to get, that their chemoreceptor trigger zone is activated. Motion sickness, that's working on the vestibular system. An obstruction of the GI tract, that's working on that GI vagal system. So then we look at, okay, if that's why we're having a nausea vomiting based on one of these 4 pathways, then we need to add a medication for nausea or vomiting that affects that pathway. That's why certain meds work for motion sickness. Others work for chemotherapy, nausea and vomiting. So that should be a review when we get to those medications. But 4 major pathways, and there they are. History, huge. Are you vomiting blood? Metamesis. Do you have pain? Are you pregnant? What medications are you taking? And is anyone else that you work with or in your household been sick and having the same signs and symptoms as you? If you're having pain, where is it located? Now we're back to the first slide, right? Quad chart of the. If you have acute nausea and vomiting with abdominal pain, we're thinking like a gastroenteritis, right? Severe pain, and that's leading us down a different pathway. Then we're starting to look at obstruction or peritoneal irritation. Ask about changes in diet, changes in meds. Ask about if they're having any other systemic symptoms, i.e. those red flags. Nausea, vomiting, signs, symptoms, acute onset without abdominal pain, food poisoning, acute gastroenteritis, systemic illness. With abdominal pain, now we're starting to worry about something physically going on in our GI tract. Peritoneum irritated, do we have an acute obstruction? Do we have gastroparesis, i.e. delayed gastric emptying or stomach emptying? Early morning sickness, common in pregnancy. Physical, observe for signs of dehydration, dry mucous membranes, skin turgor. You're looking at the tinning of the skin there. Clinician pulls on the skin, a lot of times the back of the forearm, back of the hand. Within about a half a second, normal hydrated folks, you don't have that crease, it kind of goes back down, doesn't stay tinted. It starts getting delayed, a couple of seconds or longer, they are lacking some fluids. Orthostatic hypotension, and I'm going to talk to you about specifically how to test it. We say it all the time, and you know, your screener, your nurse, your medic, whoever says, oh, we did orthostatics, and these are the findings, but did they really? Because there's a specific protocol and process you have to follow that we're going to talk about. And then if you get some predefined changes, we say, hey, this person is having some fluid deficiency. Physical exam. Obviously, nausea and vomiting, you want to do a full physical exam. Is there any tenderness and palpation? Is the abdomen distended? Is there any organ enlargement? Remember all the tests you did, freshman, sophomore, you feeling that liver's edge that you never really felt. So when you start having organomegaly, you may actually feel it. Here's the steps. Look over them for orthostatic hypotension, very specific sequence, right? And the big takeaway is within 3 minutes, and it's on the next slide, when you go from that lying to after standing for 3 minutes, so you're lying, then you're sitting, then you're standing, and if there's specific changes for the systolic or diastolic blood pressure or increase in the pulse rate, and I'll give you the specific parameters, but basically after 3 minutes of standing, when you follow this, if the systolic drops 20 millimeters of hydrogen or more, or the diastolic drops 10 millimeters of hydrogen or more, or the pulse rate increases by 30, then this patient is fluid deficient. They're hypovolemic. You need to know the orthostatics. Boards ask about orthostatics. So there's the interpretation. Orthostatic hypotension, greater than 20 systolic drop, greater than 10, or the heart rate increases by 30 beats per minute, hypovolemia. Even if the orthostatics for the blood pressure don't meet the parameters, if you see that heart rate increase by more than 30, I'll go ahead and treat it as hypovolemia. And that's the last bullet on the slide. So independent of the 3 minutes after standing, changing the systolic, diastolic, if you get the pulse change, hypovolemia. Further workup. Labs not always indicated for nausea and vomiting. It's guided by your H&P. But if it is indicated, after you do your full history and you start doing your physical exam, you want some labs. Usually we start off with just CBC, BMP, CMP, and there's a list there of other things to consider. If you're worried about liver, obviously you want to look at it, look at those changes, amylase lipase for the pancreas, acute kidney injury, start looking at those UN creatinines. Usually no radiographs unless you have some warning signs, right? The warning signs or symptoms. Then we can look at plain films or a abdominal CT if we have more severe signs and symptoms or worrisome alarm signs and symptoms. Complications, hypokalemia, because you're vomiting it all out, right? Metabolic alkalosis, because you're vomiting out acids, so your blood is getting too alkalinic. Prerenal acute kidney injury, Mallory-Weiss tear. That's just a tear in the submucosa or the mucosa of the esophagus. More worrisome is Borje's syndrome, which we'll talk about more in the esophagus lectures, but forceful vomiting, chest pain, subcutaneous emphysema, Borje. It's a full tear of the esophagus lining. Rupture of the esophagus. Medical emergency. These all listed on the slide can be complications from prolonged vomiting. Treatment, usually just supportive care. Fluids, oral fluids if they can take it. Right? If they're vomiting up after sips of water and Gatorade, or Sprite, or ginger ale, then obviously we have to start thinking IV. But if they can take oral, it's more patients. Talk to them about a BRAT diet. What does BRAT stand for? It's bland foods, but anybody know what the acronym is for? You got it. Everybody here? All right. Ginger, natural remedy. Don't forget profile or work note, especially in our population. Not everyone needs an IV. Despite what we do in aid stations and out there in roll ones, not everyone needs an IV. Greater expansion of circulating volume with enteral fluids for a greater period of time than parental, than that IV. If they can tolerate it, PO, give them oral rehydration. If they can't, IV, obviously IV is the only option. But the enteral fluids expand the volume longer than IV if they can take PO. Antiemetics. Well, we talked about the 4 different mechanisms, and we've had pharmacology in sophomore semester for nausea and vomiting. So our classes are the 5-HT3 antagonists, aldosterone, so Zofran, dopamine antagonist, promethazine, anticholinergics, scopolamine for that motion sickness of the vestibular system. Basically, if you can identify the pathway or the cause, use a medication that works in that pathway. Meclizine for motion sickness. Zofran for your chemo patients. Just a couple of the clinical pearls there. Consider the degree of vomiting when you write medications, because can they keep it down if they're vomiting every 5 minutes and you're giving them something that's not rapidly disintegrated and bioavailable quickly, or are they vomiting what you just gave them right back up? If they can take PO, go PO. Right, moving on to hiccups. Involuntary contraction of the diaphragm may only involve one hemodiaphragm, left or right. Definition, syngultus hiccups, involuntary contraction of either the left or the right, or both sides of the diaphragm. Usually benign causes, gastric distension, alcohol again, just like dyspepsia. Changes in temperature can actually cause hiccups. Stress-induced hiccups are a thing. With the gastric distension, some of your players are carbonated beverages, a lot of air swallowing, or overeating. taking in a lot of air, they're eating so quickly. Sudden temperature changes from hot to cold can cause them, cold to hot, alcohol, and states of heightened emotion, so emotional excitement, stress, all can cause hiccups. When do we start to worry? Well, if they're persistent, if they're there going on, a day or more, then we have to start looking at, is there a CNS cause? Is there something metabolically going on? So we start doing that workup with labs, right? Phrenic nerve or vagus nerve irritation that's causing it. You do need to know that there is a medication that you can use for irretractable hiccups. You might know what it is. It's not on the slide.
Yep. Step door.
Chlorpromazine. Chlorpromazine. You need to know it. Irretractable hiccups. Chlorpromazine. Chlorpromazine. I think it's on this next slide. As I said, hiccups, if they're persistent, may be signs of underlying CNS, metabolic, or nerve irritation cause. Can be post-operative, and I mentioned can be psychogenic. Full history and physical if you have irretractable hiccups. Here's some of the other anecdotals. I don't know if they work. Teaspoon of dry sugar, I'm sure we've all heard it. Never tried it, never had a patient do it. Stimulation of nasopharynx, right? You need to put a cotton swab in a nasopharynx or gloved hand and stimulate the nasopharynx. Valsalva maneuver, I mean, you name it, everybody's tried to get rid of hiccups, right? Seriously scary, apparently works. I've seen many people attempt, never seen it actually work out. Relief of gastric distension. If it's gastric distension that's causing irritation of the phrenic or the vagus nerve, relieve that distension. Sometimes it helps. And then Tegretol, chlorpromazine. It's an old, antipsychotic, right? It works. Anecdotally, I had a pilot on a fob that had irretractable hiccups and had to be grounded in Afghanistan while we sent him to, it just wouldn't go away, so he couldn't fly. And they ended up putting him under anesthesia, actually. And I don't know if they inserted a breathing tube or not, but he was down there for like a week, and that was finally what got rid of it. But that's the only case of irretractable hiccups I've ever seen. But they did try the Tegretol, did not work. Gastrointestinal gas, belching, eructation. Make sure the medical terms are only slides, like for the belching, the flatus, all these. Don't just learn the slang term. Make sure you know eructation. Normally, again here, swallow a lot of air. You can get transient lower esophageal sphincter relaxation. Usually, belching is benign, just like hiccups, on less symptomatic. A lot of times after meals, this is obvious, right? We've all seen it. Gastric distension causes that relaxation of the lower esophageal sphincter, and then you'll get belching, normally from swallowed air. Not a problem unless it becomes way symptomatic. So gas, flatus, farting, gas in the intestinal tract. Gas passes through the anus. Two sources, swallowed air, only nitrogen, and also bacterial fermentation of undigested carbohydrates. And we're going to talk about FODMAPs and what that means. Usually the foul smell is from hydrogen sulfide, ammonia, methane. Important thing to think about other than the swallowed air is the bacterial fermentation of undigested carbohydrates. So when we talk about FODMAPs, we're going to look at a patient's diet that's having a lot of flatus. And FODMAPs is the fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. What does that mean? The carbohydrates, lactose, fructose, polyols, and the fructans, they're fermentable. And so when they ferment, if you're having them in your diet, that's what can cause the foul-smelling flatus. So what do you have patients do? Avoid FODMAPs foods. And I actually have a chart of it on the next slide. And there's a couple of over-the-counter options for you there. Reno, Lactaid, Gas-X. If you're having discomfort, gas, or excessive flatus. If it's chronic bloating and gas, start to consider maybe a malabsorption syndrome, but you could trial them on a decreased FODMAP diet first and see if that eliminates the issue. There is FODMAPs, the carbohydrates that you can avoid, and see if the patient's flatus symptoms decrease. The next slide is actually just a visual of the same thing. Which foods you can have patients avoid, just give them a FODMAP avoidance diet to see if their flatus decreases or their bloating. All right, like I said, this brings us to the memory jog. I won't go through all of them, but this should anchor your studying. And branch out from there. It's not all inclusive, as it says on all the slides. But what I would ask that you pay close attention to is any alarm systems, right? So what would alarm symptoms for dyspepsia be? They're right there on the slide.
Ulcers.
Right. Over 60, weight loss, dysphagia, recurrent vomiting, family history of GI cancer. So those things, what do they get? A trial of PPI, H. pylori testing. They probably get H. pylori testing, but yeah, they get an EGD. They get an upper endoscopy. And we said that cutoff for new dyspepsia, always EGD is 60. New onset above 60. Did not pass go, collective EGD. What's the static criteria? After lying, sitting for a minute, standing for 3 minutes, positive for systolic is what? Greater than 20 drop. So not increasing. So it's kind of counterintuitive. More than 20 millimeters drop. What about for diastolic? And then what about the pulse for hypoglycemia? Greater than 230. Most common chronic dyspepsia. What causes it? Most common cause of dyspepsia. Functional dyspepsia. Correct. What two tests do we prefer for H. pylori? Okay. And then how long do we treat? 14 days, and then retest. If we have treatment failure, what do we get? EGD. Awesome. All right, let's take 15. Hey, we can start back sooner if you want.
I heard you complain and now you're not complaining.
I said good.
Stop complaining.
I'm like,
We're gonna be.
no. There's caffeine, there's carbs in those. But easy digestible carbs. But not bad. Yeah.
Sometimes I buy the healthy stuff and they want flavor and I end up eating it. Wait, no. And I feel like so far it is.
Mine's working tomorrow. Yeah. Yeah. Yes. No, yeah, just. You know, you get the chart. Yeah, I want. Just know it's a thing and what it's used for. If you have excess fat or bloating, try this diet first before you start running. In that case, pull it out. EGD is not going to get down into where the gas is.
As long as you know it's applesauce and not on the test.
This guy, you got the cookies?
I've had to like Kyle, when you said thank you. Yeah. Good. The animation of you.
What a goober.
I was like, he's gonna
I punched my kids. Dude, like, that was one of those things that got me to go back in school. Going up, boom. Scream, boom.
Because they're like, you still can't do it. So it's making an effort to actually.
I'm gonna practice this.
And then kind of just a cool watch. Looks at the car.
try some potatoes, rice, and avocado. I might fix it. Yes, that too. No, I wouldn't.
Trying to sneak a snicker now?
Scott, I don't know if like this is all my reviews.
That's the problem with that. I got a lot of right
It was like an $8 coffee. Me and Tyler.
You'll actually get some reward.
You both get
Oh, they're like, who has the car? Like, this is not even you just say that you'll be able to spend like
all the new national guard.
Trying to do this during school hours.
Who was that?
No, get out of here.
We're all fighting for referrals already.
I will say that's changed the game. I didn't know I could get it right. As an idiot, you got hurt first and then got flat. You gotta get this one too.
Well, I would say just, but yeah, just very similar. So like the first 300 a year you spend on drugs is reimbursed. And that can be gas. It's another one, 21, because like $700 annual. There's an extra $200 there.
When you combine layer up on that, rising.
Res is important. Actually, you go use it. I really like res. I go to Shira. Even though it's free, I still hate the resistant cost. No, I shut it down.
Yo. No, it's just locked. I was thinking he's probably just updating it because he does that pretty late where like it's oh did he? I'll get there when I get there.
I'd rather see them play
Denied. So nice. Yeah, I think he's not shit. I'm trying to go to
Good. Salmon on fries. It's like you'll have this they just put extra
Simple and rough though, I think.
They want some. I'm a fan of fried.
I like fried more, but steamed.
I doesn't care what you say. Fried. South Carolina. Whatever. There you go. And she would make she said like it makes trade month or whatever. But microwave before you're there. Because they're pretty fried. Still like crisp. That's right. Like tastes so great. It's all the gas station is like it's so funny. They have like a whole pile of like ramen, all the different ramens. But you have to find the water faucets there. Put it in the water.
I mean, I'm still gonna talk to him about one.
And then like, in general, like,
Yeah, I'm still gonna talk to him about
That's on my bucket. My wife said
expensive. So I think just getting there, there's, accommodations are not actually, what about you stay on base? You're looking at $100 a night. It's something like crazy. Travel. They also do have like auto tones, similar to a hospital, but not quite a hospital. Because it's really just it's still private. You get a bar or
It is like
everybody's clean there, so even if like you go back, they're getting
it's like actually to get my first too.
Then I got
you know how they build their substance.
And I'm really confident they could handle it. So they know how to handle it.
Added in a bowl, that is good. More times you can get in.
And even if I try to have this
I've got 11. All right, continuing on, part 2. Next, we're going to discuss constipation and diarrhea. Remember, much like the first hour, these are not diagnoses, right? These are symptoms. Basically, you just have to determine are they benign symptoms or are they dangerous symptoms. Require further workup, just like the first hour. So we're going to look at interpreting signs and symptoms, forming the differential, and then determining who to work up, how to work up, and then how to treat it. Often constipation, diarrhea, simple, right? But sometimes with the first signs, something more obvious, like malignancy, obstruction, or inflammatory bowel disease. So constipation and diarrhea, not diagnosis, just symptoms. You got to figure out benign or not. Is this the initial sign, constipation, diarrhea, of a malignancy, some type of GI obstruction? Is it a sign of an inflammatory disease process or a systemic or autoimmune process? Most, like I said, are simple, but you can't miss the ones that aren't simple. The Bristol stool chart. This is helpful for the patient to review and describe to you the stools that they're passing. I think Bristol is somewhere in the UK, Bristol Infirmary, but they came up with this about, I don't know, about 10 years ago, I guess. But basically to help the patient describe to the provider when they're describing their diarrhea or constipation, the type of stools that they're passing. So what is constipation? Well, we have to ask what's normal for each patient, right? So the patient that's presenting, subjectively, what is their normal and what are they defining as constipation? What is normal for this patient? Some folks have a bowel movement every other day. Well, if that's their normal, it's not constipation. But other folks may have bowel movements 3 times a day. Then if they go to every other day, now it's obviously constipation. So it's all in reference to what's normal for your patient. Most patients would say fewer than 3 bowel movements a week, passing hard stools, straining, or incomplete evacuation, or feeling of incomplete evacuation as well, is constipation. But it's subjective. Just remember, constipation is subjective. But we do have a criteria. The Rome Foundation, I think it's a non-profit NPO, NGO, experts around the country, but they came up with this objective criteria, the Rome 4 definition for constipation. So this is the one clinicians use to define clinically constipation, in addition to the patient's subjective, what they're telling you about their constipation. So for the Rome criteria, 2 or more of the many bullets down below it. Straining more than 25%, passing hard stools, incomplete evacuation, having to use manual maneuvers to pass stool, i.e. digital removal or breaking up of the feces to pass it. Manual maneuvers including pelvic floor relaxation, i.e. you've probably heard of folks getting a stool so their knees are up above the toilet, kind of taking pressure off the pelvic floor to help with evacuation. Or less than 3 spontaneous bowel movements a week, among the other things that are listed. Usually you're not going to have loose stools with constipation, but you can have paradoxical loose stools if your patient is taking laxatives, or if you have a fecal impaction and then fluids are going around the impaction, so it's paradoxical, right? I have constipation, but yet I have diarrhea. That's usually you have a fecal impaction, and then fluids are moving around the impaction and giving you watery diarrhea, but you also have constipation from the fecal impaction. So then you have to go in and usually digitally help remove the impaction, and then usually we give an enema too. We'll talk about that coming up in the next couple of slides. So loose stools, only with laxatives, and you can help distinguish your functional constipation from irritable bowel syndrome with constipation based on if they're getting relief when they go to the restroom. So after they defecate, if they get relief, it's usually irritable bowel. So abdominal pain improves defecation, think irritable bowel syndrome. We're going to have an entire hour on irritable bowel later this week or early next week. If pain is not dominant, then think functional. Functional reasons for the constipation. Primary versus secondary etiologies. Primary is inside the colon. That's why it's primary. Slow transit, so feces is moving slowly through the colon. IBS, or irritable bowel syndrome, more predominant constipation type, also inside the colon. And dyssynergic defecation. Basically, the pelvic floor, the abdominal musculature, and the rectum are not working in unison to pass the feces. So you get spasming, you get abdominal cramping, but everything's not working in unison between those three, between your abdominal muscles, your sphincter, and your pelvic floor. Secondary etiologies is something else, right? Just like with dyspepsia, sudden onset in an older adult, red flags should go up. If it's sudden constipation in an older patient, rule out malignancy. Work them up. Review medications, right? Certain medications we know and you've been taught lead to constipation. Verapamil is a huge one. Iron, opioids. I know that we've had that in pharm. First semester, opioids. Sometimes you have to give a laxative for your patients that are on chronic opioids or short-term high-dose opioids because it causes constipation. Iron, anticholinergics, hypothyroidism can cause it. So basically, if it's not in the colon, it's not a structural abnormality or a systemic problem that's primary, then we start looking up all these secondary causes. Secondary, usually more sudden, and you don't have a prior history. And we'll get a little bit deeper diving into the etiologies and the secondary causes here. Primary problem, always inside the colon. IBS and constipation, as I mentioned, and then that dyssynergic defecation, pelvic floor, anal sphincter dysfunction, not working in unison. That's what the dyssynergic defecation means. So you're straining, abdominal muscles are spasming, but the sphincter is not relaxing, why we need a pass. And the pelvic floor muscles are tight. Secondary constipation outside the GI tract, think endocrine, diabetes, hypothyroid, metabolic disorders, hypercalcemia, hypokalemia. So sometimes medications, as we know, can lead to some of those electrolyte and mineral imbalances. So if you start getting high calcium in the blood or low potassium, then you can get constipation. You can have mechanical secondary reasons for constipation, including obstruction or rectocele. We'll talk more about that when we start talking about the lower GI tract. Pregnancy can cause constipation. Certain neurological disorders, Hirschsprung, MS, spinal cord injuries, and Parkinson's. Usually, constipation as a secondary cause is multifactorial in nature. Congenital constipation etiologies. I mentioned Hirschsprung, hypoganglionosis, congenital dilation of the colon, small left colon syndrome. I'm not going to ask you specific congenital causes. Just know that there can be a congenital cause of constipation. Medications I mentioned are listed there. A couple I didn't, the antacids, and I talked about the changes in the minerals. So your diuretics, we discussed in block 1, leading to those mineral changes, specifically calcium and the potassium that can lead to constipation. Overuse of anti-diarrheal medications, that's a big one. If you start taking a whole bunch of loperamide, you're going to lock it down, and now you got constipation. For exams, you need to know new onset constipation with weight loss and anemia, get a colonoscopy. Rule out malignancy. And that's it more further than slides. Other etiologies, not getting enough fiber in your diet, not getting enough fluids, poor bowel habits, i.e. holding it too long, or the big alarm, right? Any kind of obstruction lesion. So for those secondary causes, you want to think systemic, right? Endocrine, metabolic, neuro, mechanical like obstruction, and always pregnancy and differential of females of childbearing age. Like I said, new constipation, weight loss, anemia, colonoscopy. Just like we use the EGD for dyspepsia, we're here going down, now we'll go colon looking up, rectum looking up with the colonoscopy. Signs and symptoms. History is huge. Same questions we ask for dyspepsia mainly, but you want to try to rule in or out and differentiate between is this primary, i.e. happening in the GI system, or is this secondary, one of those systemic causes. Ask about the meds and ask about prior history of constipation, because we talk about new onset, older population being more worrisome. Physical exam, do the DRE. Do the DRE. Don't bypass it for your constipation patients. Because if you don't do the DRE, you're going to miss the pathology. So if your patient is having this paradoxical diarrhea, if you don't do a DRE, you can't diagnose the impaction to help get rid of the impaction so that they can start having normal bowel movements. DRE helps you rule out structural abnormalities or that there's a blockage of the GI tract due to hard stool in the rectal wall. anyone with your constipation, or the diarrhea, those patients do the DRE. Don't forego it. You need to work up those that are over 50. You need to know that age. We talked about dyspepsia, new onset, EGD is over 60, but constipation, new onset, over 50. Hematochezia, passing blood, right? Weight loss. What is FOBT? Positive FOBT. I don't even know if it's on yours. Yeah, at the bottom there. Fecal occult blood test, right? Do the DRE, and now you can actually, probably right there in your clinic, wherever you're at, put a little enzyme on there, and if it turns a sudden color, hey, there's occult blood. We need to do a full workup on it. Family history of colon cancer should set off an alarm for you, or severe constipation. So if they have that blood in the stool, weight loss, positive fecal occult blood test. They also have the ones that you can like get in the mail now and mail off. If you want to do it that way, not to have a fecal occult blood in the office. But you as a clinician should do the DRE. So if you have the alarm symptoms listed there below, now we're going to go ahead and move to a colonoscopy. Just like upper with dyspepsia, we will move to an EGD, up looking down. Now with the alarm systems, we're going from down looking up, doing the colonoscopy. Avoid over-testing. You really should only be imaging those folks in that alarm system symptoms category. Basic labs to work up constipation. Same, nothing new here, right? Except for go ahead and add the TSH in. So CBC, CMP, calcium, TSH, glucose. When you do your CMP, you're going to get the calcium and the glucose. If you do radiographs, if you have concern, alarm symptoms, you're going to get with constipation a lot of times just a non-specific bowel gas pattern. You'll just see gas all throughout the small and large intestine. And I know y'all have X-ray class too, so I'm not going to dig too deep into picking things out on the film. And then a colonoscopy only if the alarm features are there. So here's some pictures. One, there's those non-specific gas patterns on the left, and then in the CT, you can see they are just backed up. Right? Fecal matter all throughout the intestines. You will not have images on this test. Well, not these images. You will not have those images. We'll talk about specific images, not in today's lecture, but next week. Lifestyle changes, diet changes, just like we manage dyspepsia, right? And nausea, vomiting. But specifically for constipation, optimize toilet habits, timing, and positioning. We talked about how they could relax the pelvic floor, get the stool to put the feet up on, but making sure that they don't hold it, that patients are going when they feel the urge. Increase fiber, right? First, we're going to do those toilet habits, and then fiber, next management in your diet and lifestyle changes. And then we're going to talk about increasing fluids and exercise helps with constipation. If the bulk forming laxatives and increasing the fiber, the fluids, and exercise doesn't help, then we're going to kind of move on down the line. We'll talk more on the next slide of what we move into after the bulk forming. Usually the Metamucil or the Cilium is the first line there. Look at the drug list. Look at the drug list and see if any medications the patient is on, and not forgetting any herbals, any OTCs that they're taking to see if it can be causing their constipation. If so, see if you can transition them off of it. Only if you can. Don't start changing folks' diabetic medications and those kind of things just because they're constipated. Probably want to start working with a specialist on that. So I mentioned first line treatment is going to be your lifestyle. Then you're going to add those bulk forming fibers into the diet. Next pharmacotherapy would be the osmotics. The board loves PEG, the polyethylene glycol, as an osmotic laxative. That doesn't work, then we go to stimulants. Senna, or the bicycle Dulcolax. Moving further down the line, we can talk about stool surfactant or stool softeners to help ease with passing those hard stools. Docusate or lubricants, mineral oil. Usually the stool softeners aren't used alone. Normally you add the stool softeners in with one of the other classifications of medications as you move down your treatment pathway. Enemas are a short-term rescue. They can be used kind of a last ditch to help open things up and get it moving again. I would know that that PEG is the first line osmotic. Polyethylene glycol. Further down the line, last ditch would be the secretogs to use for chronic constipation. They're very expensive, and make sure they fail everything else on the list so you can justify why you're putting on these medications. Normally, when you get to this slide, you want to have a gastroenterologist involved. You're probably not managing this without a specialist if you're on this slide. If you're down to fourth and fifth tiers, fourth and fifth line treatments, you're thinking, okay, we can try secretogs. They should be in coordination with a gastroenterologist. Know that these are treatment options. Just know that you're going to have a specialist on board when you get to this level of treatment for constipation, as they failed all other attempts. Complications. We talked about fecal impaction and how it can cause paradoxical diarrhea. Liquid stool goes around impacting feces. Manually disimpact, followed by a oral retention enema or mineral oil, and clinical note, stand to the side. When you do this, don't be directly in line of fire. Make sure you know fecal impaction treatment. That's why you have to do the DRE to see if they have impaction for constipation. So long-term constipation, complication, straining of the stool, straining when on the toilet, results in chronic dilation of the veins of the rectum, known as hemorrhoids, internal and external, right? So chronic straining leads to hemorrhoids, and then we're going to talk about lower GI tract later this week. How that's bright red blood on the toilet paper, pain with defecation, and chronic constipation with your external hemorrhoids in the room. So you want to get that impaction gone, and you want to help your patient with their constipation, relieve the pressure on them passing stool so they don't develop hemorrhoids. Constipation, if it's refractory, when you're down to the fourth and fifth tier, I said refer, get a specialist involved. Or if your colonoscopy or flexible sig, which we're going to talk about the differences, why you would use each one in other lectures. So that's why I didn't deep dive colonoscopy versus flex sig. But if you find a structural abnormality, get a specialist involved. If they have those alarm systems we mentioned and over 50, refer for some scope, whether that's colonoscopy or flex sig. If not, simple, no red flags, treat in primary care. As much down that treatment algorithm that you need to go before you start looking at secretogs, and it's time to get a GI specialist involved. Right. Diarrhea. Again, we got to find normal, right? Diarrhea, normally we would say, 3 or more stools per day that are loose and watery, and patients have an urgency. Frequency alone isn't just diarrhea. They gotta be loose and watery. You can refer to that Bristol stool chart to see how those are classified. And then they have to have urgency. Once again, diarrhea, ask your patient, what's your normal bowel habits? Find your normal bowel habits. Normally your patient's going to say increased frequency or that watery loose stool. And urgency. Got to be near a toilet, right? When you gotta go, you gotta go. Normally what your patient's going to give you is feedback from what they're experiencing with symptoms. Etiologies, exhaustive. Huge, huge list. We'll hit some big players, but you're never going to be, diarrhea can be caused by so many things. But what we're going to do is just worry about categories mainly, which will lead you down the proper treatment or workup. First of all, you have to say acute or chronic. And then inflammatory, non-inflammatory. Now you got it 75% figured out. Acute, less than 2 weeks. Chronic, longer than 4 weeks. Don't ask me about 2 to 4 weeks. There's no definition for 2 to 4 weeks, but less than 2 weeks. Acute, longer than 4 weeks. Chronic, I guess we could say is persistent. There's no accepted term for the 2 to 4 week time period there. So know those categorizations. And then once you know if it's acute or chronic, that's easy. How long has this been going on? Then is it inflammatory or non-inflammatory? Is it bloody? Do you have a fever? Is it non-bloody? And you have no fever. About probably 80% you can figure out from those two questions. Acute, chronic, inflammatory, non-inflammatory. The big difference between the inflammatory is blood and fever. Non-inflammatory is going to be water. History. Well, if that's what you're trying to get to categorize with those two questions, then you need to ask. Is it bloody or watery? Non-bloody. Did you have recent travel? Diet changes, new restaurant, new food types, recent antibiotics. Antibiotics are a big one, especially in hospitalized patients because of what? C. difficile. Sick contacts. Anybody else sick? Got diarrhea in the household or close working relationship? Severity. Mild, moderate to severe. So mild, tolerable, non-distressing, doesn't interfere with your plans. Moderate is a little distressing. I might have to change my plans. I might have to go home earlier than I thought. Severe, I'm going nowhere. I'm done. This has me, my full undivided attention is being close to a toilet. And you need to know if it involves dysentery, which just means bloody diarrhea. Acute non-inflammatory, less than 2 weeks, watery, non-bloody. Usually mild, self-limited. Cause usually virus or non-invasive bacteria. Don't usually work it up unless it's really severe and it's now we're going past that 7-day mark. We start getting past a week, start working it up. It's still acute, because it's literally acute until 2 weeks. But at about the 7-day mark and severe symptoms, start working it up. But by then, you should see the signs and symptoms improving, or else you're going to get some things back on the tests we're going to run. We'll talk about what those are. Basically, keep them hydrated at that point. Common etiologies: acute non-inflammatory, viral, cruise ships, it's on the news like every other week. Hundreds of passengers, near the toilet, having a viral illness. Rotavirus, passed amongst children. Enteric adenovirus, stomach flu. And then Giardia, normally you'll see that. Your stem will say like, went camping, went to a water park for Giardia. But these are all non-inflammatory acute causes. Like I said, mostly viral. There's that one protozoa there. You're gonna get all of these and more than you want in ID. We just need to make sure that you're knowing what some of the common causes are, but we're not gonna get into, how do we diagnose it, how do we treat it, like, just the classic stems there, right? Cruise ships and canteens, that kind of stuff. I'll let ID beat you up on the treatment, management, and all that, viral or protozoal infections. So acute non-inflammatory, we said loose watery, can be up to 10 times a day. Cramping, bloating, common. Nausea, vomiting, common. Well, we can do orthostatics and give them fluids. If they aren't having nausea and vomiting, what kind of fluids do we want to give them? Oral replacement. If you have to do an IV, do an IV. Do your orthostatics here as well. We explained it in the last hour. Check the skin turner as well. Continuing on with acute inflammatory diarrhea. So we were acute non-inflammatory, less than 2 weeks. Now we're acute inflammatory. Guess what? We're bringing in all the stuff we said wasn't in inflammatory. So now you've got fever. Now you've got bloody diarrhea. Now you got lots of pain. You got leukocytosis if we start running a CBC on you. Tenesmus, right? That muscle cramping, abdominal, feeling like you've got to go, abdominal cramping. Now we're talking about invasive or toxin-producing bacteria, usually. You got blood or pus in the stool. And once again, it's acute, less than 2 weeks. Now we work this up, right? How do we work it up? There's a long list, but we're going to start with actually checking the diarrhea, checking the stool, right? We're going to look for bacterial cultures. How do we do this? We collect samples, usually on 3 different days. We send it off to the lab, and they run a bunch of tests. We talked earlier about for the protozoa, or the parasites that we look for ova and parasites in the stool, but we also do a bacterial culture on the stool. Test for Clostridium difficile toxin. So that's a special assay that the diarrhea can be tested for to see if it's from C. diff. And then I mentioned the ova and parasite for the eggs or the parasite themselves. So we'll do the stool culture. We'll do fecal lactoferrin. That's just a non-specific sign of inflammation in the GI tract. I think it's further defined on another slide. Common etiologies, these bacteria, right? E. coli, Shigella, Salmonella, C. diff. We talked about the antibiotic use. Recent antibiotics are hospitalized. Start looking at C. diff. But you can send the stool off when you do the culture to see what grows. And when they look at the microscope, see if there's ova parasites, you can also request the C. diff evaluation. And it'll actually look for the toxins that are specifically made by C. diff. And then you can give some VANC, which is kind of the drug of choice time now. That won't be on your chest. I won't ask you how to treat C. diff. Symptoms, acute inflammatory. We said loose and bloody. Lots of times this is lower in volume than your non-inflammatory, which is watery. Because now we've got blood and sometimes some pus in the feces. Fever, severe left lower quadrant cramping. Urgency, like I said, full devotion towards the toilet. You gotta be near it. Tenesmus, that's that rectal cramping. I feel like I need to go, or I feel like I'm incompletely evacuated the feces. That's a constant cramping and feeling like you have to go. Urge to evacuate the bowels. Physical, usually non-specific. Like I said, check for dehydration, hypovolemia. Abdominal exam, see if it's distended, bloating, look for jaundice. Bowel sounds, the borigamy, right? Just the gurgling of your gut. Pain, or there's that organomegaly again, right? Make sure that we don't have an infectious cause that is leading to an organ disease process. And we're still talking acute, less than 2 weeks, but now obviously we're talking about infectious. So for non-inflammatory, self-limited bowel, as I said, usually no labs unless you get over those 7 days, or if it's just very severe and constant, or if their dehydration is getting severe. Then we need to work it up with labs. But inflammatory, all these cases are worked up. If it's bloody with a fever, for diarrhea, work it out. Fever, white blood cell count of 15,000, bloody stool, severe pain, frail or elderly, work them up with acute diarrhea, even though it's less than 2 weeks. Immunocompromised patients, if they're on a medication that makes them immunocompromised, or they have a disease process that makes them immunocompromised, work them up. There's antibiotics again. Obviously, we're looking for C. diff. Otherwise, if they don't have these signs and symptoms, then we can treat it supportively. But these are your red flags to evaluate for acute diarrhea. Here's your labs to work those folks up that meet your criteria. Routine blood test, CBC, CMP, amylase lipase, looking at the pancreas again. When you send that stool off, fecal leukocytes, if it's positive, there's fecal white blood cells, and it's inflammatory. They won't be there with non-inflammatory. The stool is cultured and see where it grows, so we know how to treat it. Open parasite, we need 3 samples to send that off. And for these, for the diarrhea labs, the evaluation of the stool, it needs to be diarrhea. Don't send hard stools. It needs to be loose stools to have the diarrhea evaluation. The assay of C. diff we talked about, if they had recent antibiotics. And the fecal lactoferrin, as it says there, is just a non-specific marker of intestinal inflammation. If you get a positive fecal lactoferrin, it doesn't tell you what's going on. It just means there's some inflammation. That could be autoimmune, like a inflammatory bowel disease, or it could be from an infectious process. It just says there's inflammation. Acute diarrhea, rehydrate. PO if you can. Water, Gatorade, Pedialyte. When you tell your patients to get the Pedialyte and Gatorade, if they get the full sugar version, make sure that they're cutting it with water. Some folks will make their diarrhea or even their nausea and vomiting worse by drinking Gatorade that's full of sugars. So have them cut it in half with water. That's just a clinical note because their diarrhea can actually get worse if they're drinking all those sugars. Oral rehydration salts can be used. Maintain a normal diet, but avoid high-fat, dairy, caffeine, and high-fiber foods. We'll get into the antidiarrheals, but if your patient has an inflammatory diarrhea, do not give loperamide. Do not stop them up and let the bacteria or the pathogen fester in their system. Acute treatment, antidiarrheals, Imodium, loperamide, kind of first line, Pepto-Bismol. These are not always indicated, only if it's severe, right? Because why? Our body has a good way of natural response of ridding our gut of pathogens. Sometimes it's just better to let it go. But never give an antidiarrheal for any type of inflammatory diarrhea. Bloody diarrhea, do not give loperamide. I would know that. Antibiotics, right? People get really passionate about antibiotics with diarrhea. So obviously if you do your labs, specifically your stool, O&P, check for markers for inflammation, check for C. diff. If the lab comes back positive for specific cause, then we'll treat it with a specific antibiotic. Like I said, that's more of an infectious disease discussion. But there are a few instances where we will give empiric antibiotics. We'll discuss those. Normally, patients, even with inflammatory diarrhea, with an invasive pathogen, they're going to self-resolve, even without an antibiotic anymore. It's not always indicated. Consider it in these cases. very severe diarrhea, non-hospital acquired, with lots of tenesmus, lots of bloody stools, severe fever, or you get that lab back and you don't see an O&P, they didn't identify any C. diff toxin, but the fecal lactoferrin for inflammation's there, consider an empiric antibiotic. Immunocompromised patients, you can consider empiric antibiotics. Traveler's diarrhea, this is the one we go back and forth all the time, like I just traveled in this country, endemic with certain bacteria or protozoa that can infect the gut. Now we're saying if it's severe diarrhea afterwards, within 10 days of that travel, you can give antibiotics, and some sources say you can give it to the patient. You might have folks come in going, hey, I'm going here, especially in our population because people get deployed all over the place. They may say, I'm traveling to this region, can I get some medication to take with me in case I get severe diarrhea or an infection of the gut, and that's it. We actually do that, and then we tell them if you have these signs and symptoms while you're there, within 10 days of coming back, you can go ahead and take this. We'll talk about what that empiric treatment is. But most resolves on its own. So you can do Cipro or any of the fluoroquinolones. I'm not going to ask you about the exact therapy, but you can do a fluoroquinolone for empiric. Also the azithromycin. Traveler's diarrhea, as I mentioned, during travel or within 10 days of return. Research is saying antibiotics can shorten the course of that traveler's diarrhea by a few days, and you can give the prescription to the patient prior to travel to use if they do get those symptoms. So, azithromycin, gram single dose is probably the easiest. But I would know those two medications for traveler's diarrhea. That's, you can give it to them to take just in case, only if they start having signs and symptoms, or if they're back within 10 days and they come in, it's within that 10-day time frame. Those are your medication choices for traveler's diarrhea. And then for the other invasive organisms, parasites, bacteria, amoebas, then I'm not going to ask you about specific treatment, but just I'm sure you're aware in infectious disease that those specific organisms or parasites or viruses and bacteria have a specific treatment. I'm not going to ask you about them, but if your workup comes back with one of these, obviously there's specific treatment that you need to give to eradicate the offending agent. Acute diarrhea inpatient treatment. There's your list: severe dehydration, toxic colitis, sepsis, hemolytic uremia syndrome, which is an acute kidney injury, thrombocytopenia, and hemolytic anemia. There on the bottom of your slide. A lot of times that's caused by enteric E. coli, but you want to admit those patients. Sepsis, admit. Thrombocytopenia, admit. So know the reasons for admission. They're on this page. And then here is your algorithm from current medical diagnosis and treatment. Everything I just said on those other slides in a nice pictorial algorithm to follow if you prefer. Chronic diarrhea. We said more than 4 weeks. These will be categorized, and we'll talk about the categories here in a minute. But you need to know what bucket to put your chronic diarrhea in. But the common etiologies are medications, osmotic diarrheas, secretory, inflammatory, malabsorption, motility, chronic infections, and systemic disorders. So you need to know those. I'm not big on memorizing things, but I would know this concept of categories for chronic diarrhea more than 4 weeks. Review the medications with everything, just like nausea, vomiting, dyspepsia, review the medications. If it's medication causing diarrhea, take them off if you can. Don't forget about the over-the-counters and the supplements. Chronic diarrhea, the osmotics. When we start talking about osmotic diarrheas, the big take-home point here, there's a calculation that you need to be aware of. But osmotic diarrheas, they resolve when you quit eating. When you fast and the offending agent isn't in your system, they get better. And we'll talk about how we characterize an osmotic here when we talk about the formula. So the etiologies, carbohydrate malabsorption, laxative abuse is a big one, and congenital malabsorption syndromes. Always ask for your osmotic diarrheas. When they get better when fasting, ask about dairy intake, artificial sweeteners. They're there on the slide for you. And you can try not having them on a diet restricting those agents, and if it gets better, then we know that that was the cause. That was what was causing their chronic diarrhea. Here's the formula. It's not very difficult. It looks intimidating. Basically what you're doing is you're comparing the osmolarity of your stool to your blood. Well, you're not, but the lab is, because you're sending the stool. The formula is 290, and I won't read all of the different measurements, minus 2 times stool sodium and potassium in the stool. Basically, it's chronic osmotic diarrhea if that stool osmotic gap is 100 or more. If it's less than 50, when you do your calculation, it's a secretory cause. And remember, the osmotics resolve with fasting, but the secretory, when you do your osmotic gap, it's going to be less than 50, and then it's going to also, secretory causes for chronic diarrhea are going to persist even with fasting. So I would know the number of cutoffs for the osmolarity gap, or the stool osmotic gap. 100 or more, osmotic. Chronic diarrhea is osmotic. Less than 50 is secretory. And osmotic goes away and resolves when you fast. And secretory persists even with fasting. Because normally your stool osmolarity is about the same as your blood. That's all that calculation is. What's the blood compared to the stool? The blood's normally 290 to 300. Secretory causes. So we talked about why secretory based on the osmolarity gap. Basically, secretory conditions are increased intestinal secretion or decreased absorption. High volume and watery with that low osmotic gap, less than 50. Doesn't change when you fast. There's your etiologies. Stimulant laxatives, endocrine tumors, alcoholism, bile salts, thyroid, and microscopic colitis. So inflammatory conditions causing chronic diarrhea. Crohn's, ulcerative, and microscopic colitis. Like I said, we'll have an entire hour on inflammatory bowel disease versus irritable bowel syndrome. Irritable bowel is not an inflammatory process. Inflammatory and bowel disease, know that that one is inflammatory. It's in the name. And then we'll subtype it down by Crohn's, UC, or microscopic colitis. Mobility disorder or motility disorders are your IBS, right? It's a disorder moving the matter through your GI tract. You'll have pain and then altered bowel habits. And remember, it's going to often, pain will be relieved after you defecate. And we're going to have an entire lecture on these two, as I said. Just know what bucket of chronic diarrhea they go into, inflammatory versus motility. And then we also have the malabsorption condition bucket, And this is a good place for us to stop today and pick up tomorrow. We'll hit a few slides left in this deck, do a little quick review, and then we'll take on a new topic. All right, enjoy the rest of your day.